Hello, so this is a documentary I found on the Northern Lights website. So I figured I would take a video of it. It's about an hour long, but it's called Healthy at Every Size. Zoom information session on eating disorders and treatment.
All right, so we are going to go ahead and get started. Thanks everyone for coming today. My name is Sarah Porter, and I'm a clinical supervisor at Acadia in the outpatient pediatric clinic. I also work within the eating disorder program as well. So today, it's basically, hopefully pretty laid back informational session on eating disorders. This week is National Eating Disorder Week, and so we like to take this opportunity to provide some education to providers, to the community around eating disorders. All right. So this is our team that we have. We're a little team, but do some really good work. So we have Dr. Allen, who you'll hear from in a little bit. He's a child and adolescent psychiatrist who specializes in eating disorder treatment. And so he works within the program, not just around prescribing medications, but to provide consultations to work with a family in that regard. We have Shannon Murray, who is a licensed clinical social worker, and she is a clinician within our program who treats patients of all ages and eating disorders. And then we have Mary Lamonway, who is our registered dietitian, and she also specializes in eating disorder treatment. And so she works with us to provide the nutritional counseling, dietitian component, and then myself, as I mentioned. So our agenda for today, we're going to talk about what is an eating disorder, the different types of eating disorders, eating disorders in the pandemic, treatment options, considerations, and resources. We'll try to end about 20 minutes early so we can leave some time for questions. If you guys have any certain pieces that you want to run by us, certainly we'll have some time for that. So as I said, this week is National Eating Disorder Awareness Week. And the National Eating Disorder Association is the group that puts this week together. And so they do a theme for each year. And this year it's everybody to have a seat at the table. And so it says, this NEDA Awareness Week, we invite everybody to have a seat at the table in a field where marginalized communities continue to be underrepresented. We welcome conversations on raising awareness, challenging systemic biases, and sharing stories from all backgrounds and experiences. So that's the focus of this week. As I said, we try to offer educational components, share resources, and be available to the community. All right, so just quickly, a brief patient story from one of our adult patients with anorexia who's currently in treatment with us. And she says, eating disorder treatment allowed me to find hope in a world that seemed so hopeless. It allowed me to start believing in myself again and realizing that indeed I am worthy and deserving of recovery. Recovery is a process. There's nothing perfect about it. But it does promise this. One day at a time, sometimes one meal at a time, you get stronger, your voice gets louder, and the eating disorder voice gets weaker, and you learn to love yourself again. So with that said, we're going to jump right into what is an eating disorder. Dr. Allen is going to talk about that and talk about the different signs and symptoms and different diagnoses.
Yeah, unmute myself. Well, hi everybody. So I'm Dr. Allen. I'm a child and adolescent psychiatrist chatting with you all from Denver. I used to live in Bangor for a long time, been affiliated with Acadia Hospital since 2015. Actually, prior to that, I'd been a locum. Is how I found Bangor in the first place. But we're very pleased to speak with you all today. Our team is, while it is small, I feel like it's pretty mighty. Most of the cases that we run into across the state, they're either going to be seen by us or the NEED program down in Saco. So I'll give you a little bit of an overview of sort of like kind of the structure of the way we approach eating disorders in the state. So certainly y'all are on the front lines. Definitely in primary care clinics, we really lean on to sort of identify some signs and symptoms, which we'll go over in a little bit, as well as getting consults and referrals from the emergency department, as well as the inpatient unit over in Eastern Maine. So anyway, we typically do a lot of screening, and I think the best use of our service is actually just a diagnostic evaluation to see if there really is disordered eating patterns going on, and then we can help triage to the appropriate level of care. Certainly, our clinic has options, which we'll discuss as far as what we can do, but unfortunately, there is a dearth of mental health resources in Maine, especially for eating disorders, and so higher levels of care sometimes have to be farmed out to out-of-state. Luckily, we have lots of contacts with different programs, and we're doing some advocacy on the level of Maine Care to get some more options for those kinds of patients. So what is an eating disorder? Well, I like to think that there are three primary kinds. There's the restrictive eating pattern types that you've probably heard of, anorexia. There's the binge eating category, and then there's the cyclical eating disorders, which is more the binge purge type eating disorders. And so you'll notice that I actually put them in that order hopefully they'll be in that order on these slides, where you have first anorexia, then the relatively new diagnosis of ARFID, or avoidant restrictive food intake disorder, then binge eating disorder, which is the most common eating disorder that we see, as well as then bulimia nervosa. There are other kinds of other specified eating disorders. There was a big change in the literature back in 2013 when the DSM went from the 4TR to the 5, which in the field of eating disorders kind of exploded, where we had some new diagnoses added. They were always there, but we now had new lingo to use to be able to communicate with other providers. So eating disorders are serious, treatable mental illnesses. And the reason why they're super serious is that we have one of them has the highest mortality rate of all psychiatric illnesses, and that's anorexia nervosa. They can affect anybody. It's not limited to just females, which used to be kind of this thought that it was a 1 to 10 ratio of male to females with eating disorders. It's now a much higher percentage we've identified in males, maybe as they've been able to come forth and aren't being overlooked. And that's more like in the 25% range of the cases we see are actually young men. Basically, they have a multifactorial kind of cause. The biopsychosocial model exists for a reason, and they're blameless illnesses. In fact, we talk so much about how they're blameless because we are so less concerned about what causes an eating disorder as what we can do to treat it. As there can be lots of shame and guilt associated with the development of the eating disorder, either within the individual or the family. Eating disorders can come out of basically maladaptive ways to cope with trauma and feeling out of control. So we do very much see them co-occurring with anxiety disorders as well as mood disorders. Specifically, anorexia nervosa tends to be more associated with anxiety and obsessive compulsive sort of situations, whereas bulimia nervosa, kind of the cyclical pattern, can be more associated with mood disorders. Of course, we still see mood disorders in anorexia as well as the full spectrum. But one is a little bit more anxious, one's a little bit more moody. You can go to the next slide. So here are the major types. So anorexia, classic. It's the one that everybody can kind of identify a little bit better with the eye test, if you will. It's a restriction of energy intake. There's a fear of weight gain, and that's the big one right there. So it has the cognitions. So you can have someone who's low body weight or not meeting or achieving their growth chart numbers, but if they are actually trying to restrict, they may fit in the next category, which we'll talk about. There's a fundamental disturbance in the way one perceives their body shape. As I talked about before, actually the percentage of male to female, males represent roughly 10 to 25%, and the risk of death when you actually have anorexia is much, much higher. So some easy warning signs and symptoms. You could have excessive or compulsive exercise, hair loss or thinning, dry or yellowing skin, swelling of the extremities, dehydration is the big one, because most people don't just tend to restrict food, but also fluids. There's either a dramatic decrease in normal growth, dropping off of the growth curve, at least 2 standard deviations, avoidance at mealtime, heart issues, and only in the female population, either the absence of onset of menses or the loss of menses. And that's sort of the body's other vital sign that we're very aware of and talk about with families, as when someone's being put on birth control, that can actually mask the body's natural vital sign from returning, and that can be kind of a way for us to know if the nutrition is actually helping. Moving on. ARFID. This is the one that some people aren't quite as familiar with. ARFID, or Avoidance Restrictive Food Intake Disorder, is essentially the same kind of starvation picture that you would see in anorexia, minus the cognitions. So it's a feeding disturbance. The most classic example of someone with ARFID is someone who can't get food intake, like if you go onto to a family reunion and you choke on a piece of food, and then therefore you develop food avoidance, and then there's this awful pattern of then food restriction and weight loss, and you're not actually trying to lose that. Very commonly seen in the autism spectrum disorder patients who have sensory issues, and so you actually have to kind of look at a much younger population that tends to have a younger age of onset. It tends to be more male relatively to anorexia. A lot of times it's actually they won't be meeting their growth curve or will be below it without supplemental nutrition. So you'll see that these patients have a very restricted food range. We're talking like 5-6 foods sometimes, like chicken nuggets, French fries, whatever, and that can lead to vitamin deficiencies. So the big one that we get worried about when we see ARFID are actually incredible vitamin deficiencies. When I used to work in New Zealand, there was a kiddo that we unfortunately didn't find until he was roughly 12, and he already developed blindness due to a vitamin A deficiency. So this is real deal stuff. And the way ARFID is treated is the exact same way that anorexia is treated, which is with expanding food range and weight restoration. Stats are that nearly half of children with ARFID report fear of vomiting or choking. But it's not just in the child population. We can see this in adults as well. A third of children with ARFID have a mood disorder, 3/4 anxiety, and nearly 20% on the autism spectrum. Warning signs are very similar to those with anorexia. Great perceived intensity of taste, smell, or texture. They don't like new foods. And so actually a lot of what we do, thank you, Mary, is working on expanding that range and introducing them gradually to new foods. We've had some real success stories there. Sticking to safe, familiar foods is a pretty common thing we see. Moving on. Binge eating disorder. So this is the most common eating disorder, period. A lot of times people will think, well, what is it about the patients who are overweight or binge eating? Is everybody that's overweight has binge eating disorder? No. If you're overweight, that can just happen. But most patients with binge eating disorder are overweight. A binge, encapsulated, is an episode where you eat an amount of food that is considered to be much, much larger than most people would consume in the same discrete time period or under the same circumstances. And it would have to occur at least once a week for 3 months to meet the criteria for that. About half of the patients that we see with binge eating actually are male. The warning signs that are typically pop up are when you find someone who's been eating alone, like in the car at paying in cash in the drive-through of a local McDonald's or whatever, and they want to hide their actions from their family members because there's lots of guilt and shame involved with that, and they're using this as a means of actually addressing underlying anxiety or mood issues. There can be incredible weight fluctuations, a lot of low self-esteem, lots of attempts at dieting, and just kind of a feeling of disgust, and then also complaints of GI issues that can come up. Notice that this is sort of isolated. If there are compensatory behaviors, which next slide, and then it becomes a recurrent cycle to it, then you're talking about more of a bulimia picture. So bulimia nervosa is a cyclical pattern where you have recurrent binging episodes with a compensatory behavior, and those can be of multiple forms. It's not just the type where you think that the person's putting their finger down their throat and purging. It also can be excessive exercise, use of laxatives, diuretics, any way that you think there's going to be a caloric burn that would be associated following a binge. And there's lots of guilt and shame involved with that. The challenge with bulimia, which has a different set of warning signs and symptoms than previous binge eating, basically they're just going to look like they have metabolic syndrome kind of issues like high cholesterol, hypertension, that kind of stuff. With bulimia, you have to really worry about what can come on with purging and or the electrolytic disturbances with that. A lot of times we'll see the first people that will notice purging behaviors are actually dentists with tooth decay. We definitely had that before. Low abnormal labs. If you see a low potassium level in an otherwise healthy individual, especially a young female, but nothing else is kind of jumping out at you from the labs, have a high suspicion for there being purging going on. Very frequently we see dehydration, sore throat, hoarse voice, mood swings. There can actually be a swapping of behaviors. A lot of times we see, especially when someone has a mood disorder co-occurring with bulimia, is that you'll see a swapping of, if the eating disorder symptoms are under control, the mood symptoms are not. It's a little bit like whack-a-mole. And so we're trying to figure out a nice happy medium with finding adaptive coping strategies to get their mood and eating patterns normalized. Moving on. There are some other eating disorders that are in the literature that we sometimes see, specifically atypical anorexia. That's where you see someone who's not of a low weight, but has had an incredible amount of weight loss over a period of time with restrictive eating patterns. There's lower frequency bulimia, lower frequency binge eating. There can just be purging alone, a night eating syndrome, a pica, you name it. There's lots of things that we can identify. Moving on. Do you want to take over from this, Sarah? And then I can talk a little bit more about medical stuff, or do you want me to hop right into that?
I guess we'll keep moving ahead, and then I'll have you jump in on the medical stuff.
Yeah, sounds good.
All right. So one thing that we know is that the best known environmental contributor to developing an eating disorder is the idealization of fitness. So our society, our culture really drives being thin as being the best. And so what we're seeing is that, unfortunately, girls, typically girls, but boys as well, by the age of 6 are starting to talk about their body, feel like they're overweight, or be concerned about their weight or their body shape or size, which is concerning on many levels. We're seeing it younger and younger. We know that 79% of weight loss program participants reported coping with weight stigma by eating more food. And then up to around 40% of overweight girls and 37% of overweight boys are teased about their weight by peers, friends, family members. And studies show that weight teasing predicts weight gain, binge eating, or other extreme weight control measures that they may struggle with lifelong. And so we have seen this within our own clinic, that we're seeing patients younger and younger. We're seeing, girls come in with anorexia, pretty severe anorexia at the age of 8, which is scary and very sad to see a child that young struggling so much. So
Sarah, 1 second. I just want to share the interesting study that had been done back in the mid-90s by Dr. Ann Becker from Harvard. She traveled to Fiji to sort of study the effects of the introduction of cable television on society. And prior to 1995, there were essentially no eating disorders in that country. And then in 3 years, they had essentially developed the exact same prevalence rate as Western cultures. So there really is a social component to the development of these illnesses with kind of more of a Western dysmorphic body features.
All right. So with the pandemic, unfortunately, we've seen not only within our program, but eating disorders in general, an increase we've seen numbers really increase across the board. There's new studies coming out with statistics. And so NEDA, which is the National Eating Disorder Association, reports that their phone calls are up by 70 to 80%. So folks calling in wanting support who struggle with eating disorders. 62% of people in the U.S. with anorexia experienced a worsening of symptoms as the pandemic hit. A third of Americans with binge eating disorder reported an increase in episodes. And eating disorder programs have seen a 30% increase in referrals, and I believe that statistic is speaking more to residential facilities. I think the numbers are likely higher in maybe outpatient programs. And so one of the a few of the reasons why we've seen an increase since the onset of the pandemic is there's been such a disruption in daily life. So we're lacking structure, we're lacking routine, because some of the things that we filled our days with, school or work or extracurricular activities, things like that have all been impacted because of the pandemic. So there's increased isolation, right? So kids, adolescents, even adults, we're not leaving our house as much. If they're living in a triggering environment, right? They're spending a lot more time at home. There's lack of social support. They're not engaging with friends and peers and other maybe supports they have outside of the home as much. Eating disorders thrive in anxious times. And so the pandemic, it has increased fear, I think, for most of us. And so this can trigger past trauma, and this can aggravate anxiety and mood and other mental health issues. Many people have been turning to food as a form of control to help manage their stress and anxiety related to the pandemic. We've also seen that there's been food scarcity, stockpiling food, which I think we all sort of experienced at the beginning of the pandemic, of not knowing when, grocery stores may restock and have items. And so this has led to, it could trigger anxiety. And so some people are finding that they're eating more because the food is accessible in there, and some people are eating less because they're fearful of running out of food. And that can exacerbate and lead to disordered eating and eating disorders. So I'm going to go through treatment options fairly quickly. I'm not sure who we have on the call who provides therapy type services. But before I do that, I wanted to share a quick quote from one of our patients. She says, although it can be scary to seek treatment, especially when one is knee-deep in the denial phase of their eating disorder, the process is ultimately a very good one. For me, it was a decision to trust this process that made the difference. And so with that, we offer a variety of therapies. I would say that we primarily use cognitive behavioral therapy and family-based therapy. That's our training. It doesn't mean that other types of therapy don't work. Actually, let me go back real quick. So CBT, for those who aren't familiar, is based on a theory that a person's thoughts, emotions, and behaviors are interconnected, but can be restructured to support new, healthier thoughts, actions, behaviors. So, when patients are coming in with over-evaluation of their weight, shape, negative body image thoughts, negative core beliefs about themselves, which then lead to restricting or binging and purging, maybe self-harm, body checking. And so what we're going to do is go back to some of those thoughts that are driving the behaviors and work on restructuring them. There is a branch of that. It's CBT-AR, which is used to treat ARFID, which Dr. Allen spoke about. So it's sort of a three-phase process. So we're doing a lot of psychoeducation to the family, and then we're starting some small changes and moving to bigger changes, setting goals, a lot of food exposure work, helping the child. It's typically a child, but certainly can work with an adult, facing their fears, starting to maybe be willing to hold a food that's scary for them. Maybe it's smelling the food, and maybe it's, trying a small bite. It's working slowly on those behaviors. This treatment modality has very heavy parent involvement and a lot of at-home homework, keeping logs, keeping track. And so that's a newer treatment modality that has come out to treat ARFID, as we've seen an increase in this disorder. I don't know if it's actually increasing or that just providers are recognizing the signs and symptoms and diagnosing it more. I'm going to skip DBT. With motivation to change, obviously that's something we assess when a patient comes in. Where are they in the stages of change? Are they coming in wanting treatment? Are they ambivalent? Are they resistant? Really assessing that. We do see with teenagers or with children, often they're resistant, but yet their family's bringing them in. And so it can take a long time to get them to a place of wanting to change, being in agreement of change. And so we see lots of teens and young kids not be happy with us, and we are not their favorite person to see. But generally over time that decreases as they progress in treatment. And then family-based treatment is otherwise known as FBT, or the Maudsley approach. We use this primarily for adolescents with anorexia. It is the treatment that has the best outcomes at this time. It's an evidence-based model that is based on 3 phases. And so the first phase is really focused on weight restoration if needed. It also focuses on developing consistent nutrition intake. Now, the tricky part of it is that what we do, not as a punishment, but as a support measure, is that we take all control away from the patient in regards to their eating. And so the parent provides all their meals, all their snacks, chooses what they eat, when they eat, how much they eat. And the child or the patient does not have any participation in food prep or cooking or anything like that. And it can be challenging during this phase. The parent is acting as the support, and what we're trying to do is to not engage with the eating disorder. So the eating disorder is going to get really loud, it's going to be very resistant, and we coach parents to how to maintain sort of the calm, be supportive, and not negotiate with the eating disorder. And so they're sitting with the child at the table every time they eat, and they're encouraging the child to take another bite, to keep eating. Sometimes meals can take a very long time, and yet they stick with it. We've had, kids get up and dump their food in the garbage, and it's like, nope, you're going to get another plate, and we're going to sit here, and we're going to do this. And oddly enough, it works. And so then we move to phase 2, where the patient begins to restore some control. And so they might pick out their snack, or they might tell mom and dad what they want to eat. They might start fixing their plate at dinner. And then eventually we'll move to sort of the recovery phase, which is very short. They're back to sort of baseline and able to have a normal relationship with food and their body. Sometimes from there they go on to have therapy if they have other mood issues, trauma, that sort of thing. All right. So moving on from that, nutrition counseling. So we have, like I said, we have our dietitian who is very much a part of the program and work with patients. So really our goal is around food neutrality and not food judgment. I think we're all guilty of saying, well, this is a good food or that's a bad food. And really food choice isn't a moral judgment. And so we work with our patients to really develop obviously a positive relationship with food, but if they're not able to get to that point yet, really developing a neutral relationship with food, because all food has some sort of benefit. We work on weight restoration to at least 100% ideal body weight. That's our standard. Unfortunately, within residential facilities, insurance may not cover that if they might stop coverage at, 95% of ideal body weight or lower. And so, which can be frustrating because we are certainly pushed for 100%, if not more. A lot of exposure work. While all of our services and our program is virtual right now, we still find creative ways to do some exposure work, whether, it's having the patient bring a food and, we eat a food together virtually, or, we're bringing in something into session to show them, whatever it is, we make it work as best we can virtually. The medication consultation, which Dr. Allen provides for us. Again, a lot of times when patients are coming in for eating disorder treatment, medications aren't indicated because they're malnourished and they really need food at that point. Food is going to be their medicine. Occasionally, they may need a PRN around meal times because they're really struggling to eat. And sometimes after sort of their eating disorder stabilizes, mood concerns might worsen or emerge, anxiety, OCD, that type of thing. And so we would refer them for a consultation. As Dr. Allen mentioned, we have very limited resources in our state. There's our program, and then there's the New England Eating Disorder Program in Saco through Sweetser, and they provide primarily a partial hospitalization and intensive outpatient services. And so, in their population target is mostly adults and some older adolescents. So we're fortunate enough to take patients of all ages. So I believe our youngest patient has been around 4 within our FITA diagnosis. Beyond that, we're looking at the Boston area, as far away as Texas, where we're sending patients to get treated. And that's really challenging. There's a lot of limitations for higher level of care, particularly if folks have main care, and we're seeing massive wait lists right now because of the increase in numbers due to the pandemic. So treatment options. So one approach that we use is the health at every size approach, and otherwise known as HAZE. And so we're not a program that's focused on weight loss. We're a program focused on size acceptance. So if we have someone with binge eating disorder come in to see us, we're not going to prescribe a diet or a weight loss meal plan or anything like that. We're going to focus on helping them maybe develop some intuitive eating skills, learn to eat based on their hunger cues and what their body feels like it needs. They're going to learn about different types of hunger. And sometimes this results in weight loss. But again, that's not going to be something that we prescribe. We know that when, and I can't think of the specific statistic off the top of my head, but I think it's 93% of all diets fail. And so we know that the likelihood of putting someone on a diet is not sustainable. And it also reinforces eating disorder behaviors and that in those messages that the community, society, culture is telling us around thinness. Obviously, sometimes there's health complications why someone needs to lose weight, and certainly that is a consideration that we may work with a patient on or refer them out for treatment. Dr. Allen, do you want to speak to the medical piece of eating disorders?
I didn't realize I'd been muted. So just a few things, really, since we're talking mostly to a primary care audience. The main thing that you need to look at is knowing how to screen for eating disorders. Probably you're familiar with the SCOFF questionnaire, which is usually the gold standard to use in office. SCOFF questionnaire stands for sick, control, over, fat, food. Those are the acronym. So the questions are: do you make yourself sick because you feel uncomfortably full? Do you worry that you've lost control over how much you eat? Have you recently lost over 14 pounds in a 3-month period? Do you believe yourself to be fat, yet others say you're too thin? Would you say that food dominates your life? These are just easy questions to give to a patient. Usually, if one or more of the questions are cause a positive response, you can easily make a referral. The best way to do that to our program is to call the formerly known as the Access Center at Acadia, which is the 973-6048 number. We're going to get to that at the ending, but please don't hesitate to reach out to us. As Sarah was touching on, the resources, while limited in the state, we do have connections to other programs. So in the state of Maine, there's our clinic. There's the New England Eating Disorder Program in Saco, which is a slightly higher level of care, so an intensive outpatient program, which is a few days a week of supported mealtime plus groups, and then a higher level of care than that, which is a partial hospitalization program. But these patients don't stay there overnight. If a patient is less than 75% of ideal body weight, or more medically complicated, they may need either an inpatient or a residential eating disorder specific program. For main care patients, the only option we have right now is Walden in Massachusetts. So we're really trying to get them to expand other options for us. Outside of there, we have private insurance. We can look at many other programs across the country, and we will then take the patient back upon them basically stepping down. Probably the approach that we get the most success from, we have most of our referrals for, is the FPT approach, the Maudsley approach, which Sarah was describing, which has the 3 phases. It is essentially the gold standard treatment to help with anorexia in adolescents, and it's really empowering the parents or guardians to take control and to feed their starving child. And so it's really externalizing the eating disorder from the patient or the kid, which is helpful because parents and guardians can become quite frustrated, as they might, that the eating disorder is kind of polluted their home and has affected mealtime pretty much every area of their life. And so the whole family comes together to address the situation. So, and these are very structured appointments that we have. It's a manualized program that was developed by Locke and LaGrange back in the early 2000s, kind of modified from the Maudsley Hospital in London, where it had been started. So if you think that we talk about FBT a lot, it's because we do. It's what we do probably the best. Aside from the SCOFF questionnaire, kind of the main things is kind of the take-home points about anorexia and bulimia that you need to know from this talk. For anorexia, medical problems are caused by starvation and weight loss. But these medical problems can reverse with new nutritional rehabilitation and weight restoration. Osteoporosis is one thing that needs to be looked at, especially after a patient's had anorexia for more than 6 to 9 months. And back when I was working at Eating Recovery Center here in Denver, we were very liberal with the ordering of DEXA scans. So the kinds of diagnostic tests and lab work that can be helpful for us when on the front end would be to get some basic labs like a CBC, a comprehensive metabolic panel, thyroid function, FOS. Please get an EKG. Things that you should be aware of, especially with patients who, when you're trying to do in-office procedures, is watch for water loading. So check urine-specific gravities, because they might want to be throwing their weights. Mind you, this is the eating disorder talking, not the patient. And it's really important to separate the two, just as I said before. I would probably recommend weighing in gowns and having them do jumping jacks before stepping on scales. It might sound a little bit primitive, but you'd be surprised how these things can get offset. Be wary of patients requesting more laxatives. Probably the only kind of medication that we would recommend usage for when you have feeling of bloating, constipation, which constipation is just basically part and parcel for patients with restrictive eating patterns, would be polyethylene glycol or Miralax. Any kind of like fiber-based substance is going to just worsen bloating and basically cause them to feel more uncomfortable and not want to address it. Don't use propulsion agents. Regarding for anorexia, specifically related to ideal body weight, how is that number really developed? Well, we look at growth charts, and that would be the best thing to look all the way back in time. So we may be asking your clinic for a lot of old information to then chart where they actually should be if they continue on that pattern over time. The whole idea of a growth chart is that some people are 25th percentile, some are 75th percentile, and so can be some families that may not be so happy with us when we're saying, well, their set point may actually be higher than the 50th percentile, and that actually may be where the brain kicks back on and these cognitions really dissipate. For patients that have less than 75% body weight, that's usually the cutoff to go to residential care. 75 to 85% is more of like that is like an insurance sort of body weight range where they really will only pay for residential. 85th and above, certainly monthly FBT for a young person, or doing more of an active approach for the adult patients. We could try to do that in clinic. And then if we're really just trying to expand the food range, that would also be done mostly in clinic. But at less than 70% of ideal really needs to be in medical settings so that we avoid the dangers of refeeding syndrome. For bulimia, mostly the concerns are related to the mode and frequency of purging. You'd be surprised how often patients can purge. And you're going to have wild fluid and electrolyte shifts that can be life-threatening due to cardiac arrhythmias. So just wanted to kind of throw that out there, some primary medical issues to keep in mind when you're in clinic. But if at any point you have questions, please don't hesitate to reach out to us so we can give you a little bit of direction, maybe even just with a phone number.
Just following up to that, we are always available for consultation, particularly if you are working with a patient and you have questions, concerns. Feel free to always call us, connect with us. We also can provide educational opportunities to staff within your program or whomever who may be working with patients and could benefit from some education around eating disorders. So within our outpatient program at Acadia, just to mention, all of our services right now within the eating disorder program are virtual, as is all of our outpatient programs at Acadia. But that hasn't stopped us. That hasn't decreased our numbers at all. So we're forging ahead with that. And likely when we do return on site, we'll maintain some sort of virtual option for folks. So what we do when we get a referral, and it's important to note that someone can self-refer, the primary care physician can refer, anyone can refer, but we don't need someone to make a formal referral. The patient can just call up and say, hey, I want a eating disorder referral, and that is sufficient. And so we're going to do a comprehensive evaluation when they come in for treatment. So we're going to ask a whole lot of questions, get a lot of historical information, consult with our dietitian, with Dr. Allen, to really make some recommendations regarding treatment. And then depending on, what is recommended for them, we'll start to move forward with that. They'll have a consultation with our dietitian at some point, and typically that's within the first or second session, if possible. We do have, as we've talked about a lot, FBT. So typically, if we're getting an adolescent coming in, that's what we're going to do. Occasionally, it may not be possible due to family structure, relationships, conflicted relationships within the family, but we do the best we can with it, or use another treatment approach. We have done it in split households with really good success. So we provide group therapy. So we have an adolescent eating disorder group, and then we have an adult eating disorder group, and that's really a supportive, safe place for folks to come to receive some support, offer support, have some psychoeducation, that sort of thing. So those groups meet weekly. We have a multifamily therapy group, and so that group is for basically families who are working with us. Generally, they tend to be our FBT families. We don't typically, although I don't want to say never, but we typically request that the patient be in treatment with us, just so we're aware of the case and sort of know what's going on. But that is a family kind of therapy group generally for the appearance, or whoever the caretaker is who's really providing the support to the patient, and that meets monthly. And then if a patient comes into us for an eval and we realize that they really need a higher level of care, we work with them to help facilitate that, to refer to a higher level of care, and then work with them until we can get them into a residential facility or a higher level of care program. Sometimes that means a medical admission to, Eastern Maine to help keep them stable until we can transfer them to another facility. But like I said, we'll work with the patient during that time, and then when they discharge from services, they come back to us. And just some quick considerations for friends, families, providers. Just some things to consider, particularly when working with children, is the impact of putting your child on a weight loss diet or suggesting a weight loss diet to a child. Talking about foods as being good or bad in front of your child, making negative comments about your child's body or appearance, praising your child's body around their appearance, maybe shaming your child for their weight, speaking negatively about people in larger bodies or praising them for weight loss. So be mindful of how do you talk about food, how do you talk about your body, whether in front of your children, grandchildren, patients, whomever. Really try to avoid good and bad, good and bad ideas about food or body, and focus more on like an acceptance. Again, if acceptance feels too hard, sort of a neutral approach. Recovery is retraining your body to take care of itself. It is necessary and so worthwhile. It allows for new experiences with loved ones, feeling at peace with your body and food, enjoying life without constant anxiety, and so much more. So with that, we want to leave some time for questions. If you want to put them in the chat or whatever is easiest for you guys, and you can ask them for any team member if you have questions for our other clinician, dietitian. Feel free to ask away. I can see. I don't know how to unmute you. Let's see.
Is it okay if I just verbally ask?
Yes, absolutely. Go ahead.
Okay, I was just wondering, for the binge eating disorders, what kind of success rate have you guys seen with the current treatment model? Have you thought about adapting the family-based treatment model or the cognitive behavioral therapy model for those?
Dr. Allen, you want to speak to that, or?
Yeah, so that's a real good question. Certainly, a lot of the binge eating patients that we've had have either already done the WOW program, which formerly was Eastern Maine, or now over PCHC. There's definitely a cognitive behavioral therapy bent to treating binge eating and kind of normalizing, the eating patterns, really getting at the underlying anxiety and self-esteem and mood issues that are involved. So there actually really can be more of a role for medication in those situations. That being said, really therapy is going to take the forefront. If you have a really strong counselor that can address kind of what the precursors to the binging episodes are and to decrease the frequency of them, I would agree with that. As far as the actual model we use, everything is... It is what it is. We use we'll take a model and then we'll adapt it to the specific individual in the family system. So yes, we can kind of do a modified FBT or CBT.
Thank you very much.
So we see in the chat, can anyone participate in the group therapy? Yes, anyone can participate in it. And if that's the only component they want to participate in for our program, that's totally fine. There's no sort of mandatory level of participation. And so the same process would be to call our Behavioral Health Resource Center, make a referral, and then they would come see us for an evaluation first, just so we can get to know them, and then they can participate in group therapy. Let's see. I just met with an 18-year-old male who has a history of anorexia, is presenting not eating, and it seems like he may have a schizophrenia spectrum disorder. How does treatment work? Dr. Allen, do you want to speak to that one?
Yeah, sure. So the challenge specifically in that case is the first thing that you mentioned, was that the patient's 18. And so, especially in the state of Maine, eating disorder treatment needs to be on a voluntary basis. And so we would need to get buy-in from that patient and try to get family involved, especially since you might be concerned about the development of psychotic illness as a comorbidity. In patients like this, you probably do, depending on how underweight they are, because patients that are underweight don't respond nearly as well to medications due to a lot of them being lipid soluble, especially with the SSRIs. But for someone with a psychotic illness, you might want to get them into management, try to treat the underlying psychosis, and as they may start to clear, their food intake may improve as well. But if there's like a pseudo-psychotic picture where being underfed and malnourished is leading to what appears to be more delusional thought process or kind of an irrational thought process, then it may just be that, again, food is fuel, food is medicine. We would try to treat that as well as we could as an outpatient. But this kind of leads to the bigger thing of what do we do when a patient becomes 18? You lose the leverage in eating disorder patients once they've hit adulthood, especially in our state, since again there's no involuntary commitment for eating disorder treatment in Maine. Mostly because there's no place to commit them to if they're really, really ill. So that's sort of the gap in the system that we have. Again, we need to have a little bit more advocacy. I just would like to bring more resources to the state. But for patients that you're concerned about, even just in regular mental health treatment, who have psychotic illness as an adult, you want to try to find some kind of family or friend that can help bring patients to appointments and really provide them with a package of care, maybe getting a case manager who can do a lot of that, a lot of the coordination.
What else? You can either put it in the chat or just speak up. Either work. The group therapy is insurance based, and so typically Maine Care, they cover it. Depending on the insurance, they do cover it. Typically, we can work with them on connecting with their insurance to see what the coverage is. Unfortunately, that is an insurance piece. There is a fee for the service. It's not a free support group. Well, thanks for joining us today. Please reach out to us if you have any questions. You can connect with us on Skype. You can email us, call us. We are absolutely available. You can find our information on Acadia's website as well. If you'd like us to, provide some more education or training, we're always happy to do that. If you want to consult about a patient or refer somebody to us, we welcome that. So thanks again, and like I said, don't hesitate to reach out.